Hello and welcome to Physio Classroom. This video is in continuation with our previous video series, which is about the safety criteria for active mobilization of critically ill ICU patients. In this video, we'll be discussing in detail about the medical and surgical condition related to active mobilization of ICU patients. So the first medical consideration is presence of unstable major fracture of pelvis, spinal or any long bone of the lower extremity. So such patients with unstable major fractures, they can be mobilized within the bed but with sufficient precaution like not to move the affected segment of the body, but such patients should not be mobilized out of the bed at all. Second consideration is presence of open large surgical wound over chest, sternum or over abdomen. So patients with large surgical wound over chest or sternum or abdomen in acute phase, they can be mobilized safely within the bed, but they should not be mobilized out of the bed at all in the initial phase in view of incisional pain, drowsiness related to general anesthesia and hemodynamic fluctuations. But in later phases, if such patients they remain in ICU for prolonged time, such patients can be mobilized out of the bed after consultations with the medical and surgical team. Next consideration is active bleeding. Patients with known uncontrolled active bleeding, such patients should be prescribed strict bed rest. So there is no point of mobilizing such patients. But patients who are at risk of active bleeding or they have impaired coagulation profile, which includes PT-INR ratio or platelet count report. Such patients can be safely mobilized within the bed but should be cautiously mobilized out of the bed because of risk of falling or line displacement. Next consideration is presence of hyper or hypothermia. Our body's normal temperature is 98.6 degree Fahrenheit. When this temperature becomes lower than 93 degree Fahrenheit, then it is called as hypothermia. Or on the other hand, if it goes up till the level of 100 degree Fahrenheit, then it is called as hyperthermia. So patients with hyper or hypothermia requiring active physical or pharmacological management, such patients should be cautiously mobilized within or out of the bed, because in hyperthermia, body already has higher metabolic rates and mobilization will further unnecessarily increase the metabolic rate. So such patients should be cautiously mobilized. Next consideration is ICU acquired weakness. Patients who have prolonged ICU stay, they develop muscle atrophy because of the prolonged bed rest or because of the sepsis. Such weakness in such patients is called as ICU acquired weakness. Patients with ICU acquired weakness should be mobilized within the bed and out of the bed safely on the basis of their baseline strength and endurance. Next point is presence of drain or any external attachment to the patients. In intensive care, there are many external attachments that are placed to the patients like femoral, arterial and venous catheters, nasogastric tube, central venous pressure line, intercostal drainage, urinary catheter, pleural drain and wound drain. Presence of any such external attachment in patients is no hindrance to active mobilization. So patients can be safely mobilized within and out of the bed. Next consideration is patients on CRRT, that is continuous renal replacement therapy. CRRT is a therapeutic technique which is used to support patients with acute renal failure. CRRT is preferred over hemodialysis in patients who are unable to tolerate rapid exchange of fluid and electrolytes because of their unstable hemodynamic state. In CRRT, a catheter is inserted into the major veins like femoral or subclavian, through which the blood is extracted out and then it is filtered in the machine and then again sent back to the major veins of the body. Earlier, such patients on CRRT, they are made to have a strict bed rest during the continuous renal replacement therapy. But nowadays there has been rich evidence which shows that such patients can be safely mobilized within or out of the bed. Next and last consideration is presence of femoral sheath. femoral sheath is an introducer sheath through which femoral catheters are inserted into the femoral artery during cardiac interventions like PTCA, which is percutaneous transluminal coronary angioplasty. This sheath supports the artery at the site of puncture and it prevents the potential arterial trauma during the various exchanges of catheters throughout the cardiac procedure. After the cardiac procedures like PTCA, femoral sheath are kept inside the femoral artery for next 2 to 3 hours. So patients with femoral sheath inside their femoral artery, they should be mobilized cautiously within the bed and should not be mobilized at all out of the bed. So at the end, I hope this whole video series will help you safely mobilize your patients in the critical care setting. Drop your queries and suggestions in the comment section below and keep learning, keep sharing and stay connected.